Today, Batch and BACAF are launching the family-friendly framework. This paper has been produced in response to members' concerns about the increasing fragmentation of services. The reasons for fragmentation are multiple and complex, but include cuts in budgets secondary to austerity measures, targets that do not represent outcomes, changing morbidities, increasing demand, the turmoil caused by reorganisation of the NHS, and not least, competition between providers as part of the introduction of the free market. The family-friendly framework is based on the best possible evidence from research and experience, the values contained within the UN Convention on the Rights of the Child, particularly those relating to service delivery, systems thinking to ensure all the parts are in place and working well together, and embedding learning at every level throughout the system to enable services to innovate and evolve. The family-friendly framework puts the journey of the child and family at the heart of the model and proposes a 4x4 framework to create an alignment and synergy between all the individuals, teams and organisations who contribute to that pathway. It starts with the basics, describes pathway components, builds networks from service and life course pathways, and finally describes how the whole system should work in order to be sustainable. Then each of these four elements, in turn, has four components. Before I describe the family-friendly framework, let me introduce systems thinking. In systems methodology, there is an input, a transformation, and an output. The output is always a changed input, for example, water, heat, steam, ill patients, health services, then hopefully well patients. All change is measurable, but not all measurable change is a success. Success is judged by various stakeholders involved in the process, including users of the service, providers of the service, planners of the service, and politicians or policymakers. The whole process may be influenced by external forces which may either help or hinder the achievement of expected outcomes. The family-friendly framework. Let us start with the child's journey or pathway for a short-term condition. Needs are identified as the ability to benefit from services. The child may have needs if the child is ill. The parents may have needs, for example, if there are safeguarding concerns such as substance misuse or domestic violence. Or the community may have needs, for example, to reduce traffic speed or pollution. Needs are therefore represented by a triangle. Ideally, every pathway starts with prevention, through protection from hazards or promotion of assets, and this construct will be explored further in the life course pathway. The next step is recognition that there is a problem, often leading to consultation. The consultation consists of an assessment, followed by an intervention or treatment. Let us use serous otitis media or glue ear as an example here. The focus in this example will be on the condition caused by inflammation of the middle ear. Otitis media can be prevented by protection from exposure to cigarette smoke and prevented through promotion of breastfeeding. It may be recognized through parental concerns about hearing impairment or potentially identified through surveillance programs. Assessments must include middle ear function, impact on hearing and language, and the family's capacity to manage the condition. Finally, the intervention is chosen based on the assessment, which may be observation, medical intervention, surgical intervention, or language intervention. Outcomes may be measured by hearing, language, or behaviour. The basics. To achieve expected outcomes, each step of the pathway must be based on best evidence, whether this is quantitative, qualitative, or econometric, delivered by competent practitioners, clinically competent, culturally competent to work with children and families, and dedicated to improving their service. The service needs to be delivered in the right setting, the right macro environment, which means safely as close to home as possible, with the right micro environment, meaning the right support, for example, equipment or IT, and finally delivered in a timely way which includes access, experience and outcomes. Relevance to commissioning. This detailed description of the component parts of pathways is particularly important for commissioning because different commissioners are responsible for these different individual parts of the pathway. Using glue ear as an example, NHS England is responsible for primary care, so covers breastfeeding promotion, and the recognition and management of hearing impairment. Clinical commissioning groups are responsible for audiological assessment and provision of the interventions including grommets, local authorities responsible for teachers for the hearing impaired, and public health responsible for smoking cessation programs at all ages and the Healthy Child program. A similar table could be used to identify which providers are responsible for each of the components. Then in the ideal world, regulation should cover the whole pathway. This four-step model can be expanded into 3 phases relevant for a long-term condition. The phases are the initial pathway, a review pathway which is cyclical, and a transition pathway. This is best illustrated with an example. So staying with hearing impairment, the incidence of neurosensory hearing impairment can be reduced with good uptake of MMR to prevent congenital rubella, recognised through neonatal screening programs, assessed within paediatric audiology centres, with interventions ranging from hearing aids through to cochlear implants. The child now enters a period of living with the condition, and regular reviews with the emphasis now on preventing comorbidities, recognising them early, assessing and then managing these comorbidities of hearing impairment, which are mainly language, social development and behaviour. The transition phase for hearing impairment is relatively straightforward, but may be a transition back to normal life for a child who has recovered from cancer, may be from home to hospital for a child with a brain injury, or the transition to a range of adult services for young people with ongoing long-term conditions such as cerebral palsy. Sadly, for children with life-threatening conditions, for example complex congenital heart disease, the transition pathway is synonymous with palliative care. Once again, the emphasis is on proactive planning for the future to improve both experience and outcomes. Life course pathways. Let us start with this diagram from Neil Halfon. On the vertical axis is quality of life, and on the horizontal axis age in years. The overlapping circles represent exposure to hazards, which reduce quality or duration of life, exposure to assets, which improve quality or duration of life, and services which hopefully contribute to health and well-being. The concept of hazards and assets relate to both lifestyles, which families can influence, and social determinants of health which are largely outside the immediate control of families. The accumulating difference between different exposures to hazards and assets relating to lifestyles and determinants are represented by the quality gap here. If we unwrap this diagram and just focus on protection and promotion, then the accumulating interplay between hazards and assets over time can be represented by overlapping circles at the different stages of childhood. At each of these stages there will be lifestyles and determinants which may help or hinder the development of long-term health and well-being. The intention is to reduce exposure to hazards and increase exposure to assets. Once again, needs are represented by a triangle, as the interventions may relate to the individual child, their family, or factors in the community. Examples of lifestyle hazards would include substance misuse, lack of exercise, smoking, or a poor diet. Examples of lifestyle assets would include a stable family, a healthy diet, access to creative play, and friendships. When looking at determinants, the hazards would include poverty, poor housing, living in high crime areas with inaccessible services. And then the flip side of the same coin would be stable and supportive communities, with a sustainable economy and regular employment, affordable homes, and few inequalities between individuals. Creating a table from these elements then clarifies which commissioner and which provider is responsible for which element. This is illustrated here using smoking cessation as an example, showing the elements that need to be in place at different ages from infancy through to young adulthood in respect to lifestyles, determinants and services. More detail of this approach is provided within the family-friendly. Networks. Networks bring together the initial, review and transition elements of service pathways together with life course pathways. Simply illustrated would be a life course pathway vertically on the left, with individuals leaving their life course pathway when there are problems and moving on to a service pathway for however long is required. In reality, life course pathways and service pathways combine for those children with long-term conditions, and the purpose of the network is to reduce the impact of the condition on the child or their family, as well as reducing any inequality of provision for different groups in society. Central to this thinking is prevention at every stage. Primary prevention, preventing the condition; secondary prevention, preventing secondary morbidity; tertiary prevention, preventing disadvantage associated with the condition; and finally quaternary prevention, ensuring safety and lack of harm throughout the service. Networks are the structure that bring all the parts together locally to ensure the best possible experience, safety and outcomes. Networks also create a framework for measures, both of health and health services, that should, in the longer term, drive improvement. More of that in the family-friendly framework. Finally, the whole system. We can put together all the networks into a comprehensive whole system. Each network covers different areas of work: maternity and neonatal, acute illness and injury, mental health problems, vulnerable children and safeguarding. Long-term conditions and disabilities immediately spring to mind. Each network is responsible for their outcomes, improvement strategies, working relationships between teams and distribution of resources. In order to do this, there has to be leadership, including integrity, accountability, transparency of decision making, and inclusivity, meaning that all the stakeholders have a voice. Values, translated into both individual and organizational culture, which in turn influences priorities and decision making. A clarity of purpose leading to improvements in health, better equity, safety and sustainable services. Finally, learning based on meaningful measures, feedback, innovation and improvement, leading to new knowledge which enables the system to evolve into better forms in the future. Although described separately as part of the 4x4 framework, these attributes run throughout the whole system. For example, clarity of purpose in respect to consultations, competence for employment, user participation and integrity. So what are the benefits of the family-friendly framework? The immediate benefits that spring to mind, and there are more in the paper, are that it ensures all the parts are in place and working well together to achieve desired outcomes without omission or duplication, essentially an integrated approach. It creates alignment and synergy between the efforts of policymakers, commissioners, providers and users of services. Prevention is integrated into every pathway. Better working relationships between teams and providers, bringing resource allocation closer to the front line. Next steps. Read it. The family-friendly framework, together with an executive summary, a PowerPoint presentation and this animation, will be available on the Batch website for you to download and read. The intention is to develop more examples of pathways, for example ADH and injury, over the next months. Share it. We would like you to share this approach with other professional groups and teams with whom you work, and both managers and commissioners of your service. Use it to develop pathways and protocols and integrated care with other teams, organizations and agencies. Finally, spread your experience and practice. When you improve your service, write it up, present it, share your learning, as we are planning to host examples of best practice on the Batch website. Thank you all for listening.